Okay, so it's 5 o'clock, which means it's time for the next edition of LVS Journal Club. And today it'll be hosted by me. And for those of you who I haven't met yet, my name is Ian Jones, and I'm the radiologist at London Veterinary Specialists. I graduated way back in 2003. I got my MRCVS imaging certificate in 2009 and my diploma in 2018 after doing an imaging residency at the Royal Veterinary College between 2013 and 2016. And if any of you guys that are listening would like any help with anything imaging related, be it a radiograph that you'd like a second opinion on, or if you'd like a chat about what might be the most appropriate imaging modality for helping you diagnose a particular case, then don't be a stranger. Give me a call or drop me a line via email. So the theme of this month's journal club is radiology, and I've selected 3 papers which we're going to run through this afternoon. I've tried to keep them relevant and clinical, and I've split them into one paper that looks at radiographs, one that looks at ultrasound, and one that looks at CT, just to mix things up a little bit. So the first paper, which is probably the one that requires most analysis, is the paper looking at abdominal radiographs. So this is a paper was published last year in Veterinary Radiology and Ultrasound. It's come out of Louisiana State University, and its title is "Performing Both Lateral Abdominal Radiographs May Not Improve the Visualization of Gas in the Gastric Outflow Tract of Cats." So in the introduction, we are reminded of why it's always a good idea to take 3 abdominal radiographs. So what we ideally would like to see when looking at any radiographic study of the abdomen are 3 views, a left lateral view, ideally the view acquired initially, then a ventrodorsal view, and then a right lateral view. And there is a reason for that. The reason is that by taking 3 views and by doing it in this order, you are maximizing the chances of gas appearing within the gastric outflow, so within the antrum and the pylorus, and within the duodenum. So if there happens to be a foreign body, say, that's stuck in the pyloric outflow or in the duodenum, you're effectively using the gas that's already in the stomach and in the duodenum as a negative contrast agent. So you're using that gas to help outline that foreign body and diagnose the obstruction. So this is really all about highlighting problems within the duodenum and the gastric outflow tract. And there is a reason why it might not be the same for cats versus dogs. So there are previous publications that look at the benefits of this 3-view radiographic technique in dogs, so left lateral, VD, and then right lateral, but there aren't really any studies that look at this in cats. And the anatomy of the proximal GI in cats is not quite the same as it is in dogs. And this is really one of the reasons why the authors would like to look into this in a little bit more detail in cats. So here I've pulled 2 pretty optimal VD abdominal radiographs from the Atlas of Interpretive Radiographic Anatomy by Coulson. And this is just really to try and demonstrate the difference between cats and dogs. So we have dogs here on the left, and we have cats on the right. And in the dog, we can see that we've got a whole bunch of gas filling the gastric antrum and potentially the duodenum. In the feline ventrodorsal radiograph, not really too much gas at all, which we'll come on to a little bit later on when we start analyzing some of the results of this study. But the difference anatomically, essentially, is that the pyloric outflow in the dog is usually on the right, so usually in this sort of region, and the pyloric outflow in the cat is a little bit closer to midline. So here it's actually pretty tricky to make out the stomach at all in this cat, because there really isn't very much gas either in the stomach or in the duodenum. It's going to be in this sort of region here, and then the duodenum and the pyloric outflow in this cat is going to be around the midline in this sort of region, whereas in the dog it's going to be here. So the aims and objectives of this study were to assess the variation in the visibility of gas in the antrum and duodenum with changing recumbency in healthy cats having a 3-view abdominal radiographic study. So essentially to take a technique that's already been described in dogs and do it in cats and see if it helps fill the gastric outflow and the duodenum with gas that might help us to diagnose gastric outflow tract obstructions, so foreign bodies that become lodged either in the pylorus or in the lumen of the duodenum. They also wanted to evaluate for the presence of gas in the antrum and duodenum in cats presenting for GI signs. So essentially, do cats with GI disease have more gas in their GI, so the stomach and the duodenum specifically, than cats without any GI signs? And so they had some hypotheses. So they decided that the pyloric antrum and duodenum will be more easily seen in the left lateral view relative to the right lateral or the VD views. That luminal gas will be seen in all views with increased frequency when the left lateral view was obtained first. So we talked earlier about how important it is to take those 3 views and to do the left lateral, then the VD, then the right lateral. So they're saying that we think that in cats it'll be exactly the same as in dogs. If you do the left lateral first, then you're more likely to see gas not only in the left lateral view but in the subsequent VD and right lateral views. And they also thought that they'd see a higher frequency of gas within the pyloric antrum in cats with GI disease compared to healthy controls and clinically ill cats without GI disease. So cats that have something upsetting their GI tract, whatever that might be, those cats are more likely to have gas in their pyloric antrum than cats without GI disease. So let's take a look at how they conducted this study. They essentially had 2 groups of cats here, and they had a group of cats that was used for a prospective crossover study and a retrospective cohort study group. And so it was the healthy cats that were the prospective crossover group, and then the cats with the GI disease and cats presenting clinically for some other reason that made up the retrospective cohort study. So let's take a little look at how those groups were made up. So the prospective crossover group consisted of 20 healthy client-owned cats. In order to be included in the study, those cats were starved for 8 hours, and none of the cats were given any sedation prior to having the radiographs taken. They were deemed to be healthy based on a physical examination that was performed by a 4th-year veterinary student. None of these cats were reported as having any clinical signs related to any gastrointestinal illness. And any cats that were non-cooperative were excluded from this study. So bear in mind that these cats were having these radiographs taken without any sedation. For the prospective crossover group, so this is the group that contained the cats that have non-GI disease and GI disease, in order to be included, those cats needed to have 3-view abdominal radiographs, so a lateral, a VD, and what they needed was to have, they randomized whether or not the right or left lateral was taken first, and depending on the order in which it was done, they repeated this 2 to 7 days later. So for example, if a cat had a left lateral taken first and then had a VD and then a right lateral, 2 to 7 days later, they reversed it. So they did the right lateral radiograph first, then the VD, then the left lateral. So for the retrospective cohort study, these cats were included based on some inclusion criteria, and it was pretty, didn't need much. So these need to be cats, and they needed to have had a 3-view abdominal series. And these were recruited based on the clinical notes which were searched between December 2011 and December 2017. So 6 years worth of clinical notes. There were lots of patients that fulfill the inclusion criteria, so lots of cats that had 3-view abdominal series, so 376 in total. They were excluded for lots of reasons. So if there was an extended period between views, defined as greater than 3 minutes, if they didn't have the radiographs taken in the right order, so for example, if a VD was taken first rather than a right or a left lateral, if a DV rather than a VD was acquired, they were excluded. If something called a compression study was done, so sometimes you can use compression paddles to try and highlight certain abdominal structures. If anybody had done that, those radiographs were excluded. And if the radiographs were deemed to be poor for reasons of positioning or centering, then they were also excluded. If they felt that the organs were positioned in an abnormal location, or for patients where there was no real definitive diagnosis, those patients weren't included in the study either within the retrospective cohort group. So once they had recruited their cats for the retrospective cohort study, these were split into 2 groups, and those with GI disease and those with non-GI disease. We've got a prospective group of healthy cats, and then we've got a retrospective group of cats that were treated on clinics for either GI disease or non-GI disease. So when they were looking at these radiographs, they had 3 reviewers who came up with some consensus scores. The radiographs themselves were randomized, and the radiologists who were scoring these radiographs were blinded as to the group that they belonged to. So when they were reviewing these radiographs, they didn't know whether this was a cat from the prospective group or the retrospective cohort study, whether it had GI disease or not. And they came up with a pretty elaborate scoring system for these radiographs. So they were scored 0 to 3 based on where they could see gas in the gastrointestinal tract. So if there's no gas present, then they scored it as a 0. If they could see gas within the pyloric antrum, they scored it as 1. If they could see gas within the proximal duodenum, a 2. And if there was gas in the distal duodenum, it was a 3. Now, for me, this is a little confusing because these are essentially categorical variables, but the nomenclature suggests continuous. So it isn't that a 3 is better than a 0. It's just a 3 means that there's gas in the distal duodenum, but no gas present. Sorry, if there's a 3, it means there's gas present in the distal duodenum, but maybe no gas present in the pyloric antrum. So I wasn't entirely sure why they decided on this scoring system. I mean, really what they're interested in is whether there's gas there or not. So they could have simplified it a little bit and just had sort of a 0 and a 1. Can you see gas in the stomach and the duodenum? Yes, no. They did use a yes or no scoring system for some of their other variables. So if they felt that there was dilation of the small intestine, then they said yes or no. If the stomach is dilated, yes or no. And then again, they subjectively assessed the gastric contents. So they described it as either homogeneous or heterogeneous. So here's a figure taken from the paper that illustrates how it was scored. So the solid black arrows indicate gas within the pylorus. So here, here, and here. The solid white arrows indicate gas within the proximal duodenum. So this bit, and then we can see the duodenum here, and there's some gas in it. And then we can see the duodenum here, and there's some gas. And then a score of 3 would indicate gas within the distal duodenum. So we just about see some gas in the distal duodenum in this VD view, and also in these lateral views. So again, we've got this scoring system 0 through 3, although a score of 3 isn't necessarily better than a score of 0. It just indicates that the gas is in a slightly different place. So a score of 1 would indicate gas within the pylorus, 2 within the proximal duodenum, 3 within the distal duodenum, and 0 would mean that they're not able to see any gas at all. And they used chi-squared analysis to compare the results for these groups, and they defined a significant result as a p-value of less than 0.05. So for the stats, they split the cats into Group A and Group B. So Group A cats had the right lateral first, and Group B cats had the left lateral first. You remember we talked about them randomizing these cats and then repeating the series 2 to 7 days later. So that's the crossover part of the study. So they randomized them and then they classified them as either Group A or Group B. So Group A has a right lateral first, Group B has a left lateral first. And that was true for both the prospective and the retrospective. And so the healthy cats and the cats presenting with GI and non-GI disease. So they did a whole bunch of comparisons using their chi-squared analysis. They compared the frequency of pyloric and duodenal gas in the right versus the left lateral. And they did that in both the healthy cats and the cats with GI and non-GI illness. So for me, it wasn't entirely clear why they included the cats with the retrospective study here, because that data is going to be certainly dirtier than the data that they gained from the prospective study. But I suppose they felt that it was better to have higher numbers. So they did this analysis for both the healthy cats and for the cats that were recruited in the retrospective study. Then they looked at the frequency of gas within the pylorus and the duodenum in groups A and B. So this is depending on whether they had the right or the left lateral view done first. And they did that first for the healthy cats, then the cats with GI and non-GI disease, so they're the cats in the retrospective study, and then all the cats, so the cats in the prospective and the cats in the retrospective study. They also looked at the frequency of gas within the pylorus and duodenum in the cats with GI disease and the cats with non-GI disease. So that's just the cats in the retrospective study. And then the same thing for the cats that were sedated and non-sedated. And they did this for all of the cats in the retrospective group, and then the cats in the GI and the non-GI disease groups. And finally, they looked at the frequency of gastric dilation. Again, this is just for the retrospective group. Compared cats with gastric dilation and no gastric dilation. Again, that's looking at the cats that had gastric dilation and non-gastric dilation, and the frequency of gas within the pylorus and the duodenum in both of those groups, and then the frequency of gas within the pylorus and duodenum in cats that had homogeneous and heterogeneous stomach contents. So I was a little bit confused about the last two comparisons. Comparing the frequency of gas within the pylorus and duodenum in cats that have gastric dilation and no gastric dilation, that wasn't stated in the original aims and objectives, so I'm not entirely sure why they included that in their statistical analysis. And also looking at the frequency of gas within the pylorus and the duodenum in cats that have homogeneous and heterogeneous stomach contents, that was also not in the aims and objectives either. So it's not really clear when they decided to introduce those specific statistical tests, and isn't really made clear in the discussion either. So moving on to the results. In the retrospective study, we have 46 cats in group A, and they had the right lateral view taken first, and 64 cats in group B. I think if we look at the age range for the cats in the retrospective versus the prospective study, it's kind of comparable. So in the prospective study, I think it was the median was about 4 years, and the range was 1 to 17. And in retrospective, it was 6 years, and the range was 7 to 18. So kind of comparable. Those cats that had non-GI disease numbered 65, and those cats with GI disease numbered 45. There's no mention of whether or not these cats were sex matched. They do mention the age ranges for these cats, but it's not clear if they tried to match them for sex. Whether or not that would have made a difference, I think, remains to be seen. So here's our first table. Now, one of the things that I want to draw your attention to here is, again, you remember we talked about this pretty elaborate scoring system. So we've got the scores at the top here, and then we've got the groups at the bottom, and for this table, we've just split it into the prospective and the retrospective groups. So the healthy cats, and then the cats which were recruited retrospectively with GI and non-GI disease. So we've got the scores from 0 all the way up to 3, and there were some cats that scored 1, 2, 1, 3, 2, 3, and then 1, 2, 3. Now, the thing for me that stands out here is that the majority of cats in both of these groups, they didn't have any gas at all. So 68.3% of cats in the healthy group, they didn't have any gas, so they scored 0, and 74% of cats in the affected groups, of the retrospective group with GI and non-GI disease, they didn't have much gas either, or any gas, they scored 0. So there really wasn't that much to work with here. So we've got sort of 70% of cats roughly didn't have any gas at all. Really, in both the prospective and the retrospective groups, you've only got about a third of the cases where you can give them any sort of score. So for me, that was the thing that stood out from this table, that really roughly 70% of both healthy and clinically affected cats, whether they had GI or non-GI disease, didn't have any gas at all in either their pylorus or the duodenum. So here's some of the statistical comparisons. Initially, we've got the comparison for right versus left lateral in healthy cats, and then in cats with GI and non-GI disease, the prospective and the retrospective. We've got right versus left lateral first in the healthy cats, in the GI and non-GI, and in all cats. We've got the comparison between cats with GI disease versus non-GI disease and healthy cats. And then we've got the rest of the comparisons, including comparisons for sedation and gastric dilation, and also homogeneous versus heterogeneous stomach contents. And helpfully, we've got a little star next to those p-values that were statistically significant. So what we've got is there was a significant difference in the amount of gas within the pylorus and the duodenum in sedated versus non-sedated cats. In cats with GI disease, in cats with GI and non-GI disease, and with all the cats. And so what that tells us is essentially that cats with GI disease are more likely to have gas in their stomach and their duodenum than cats without GI disease. We've also got significant results here for cats that have a dilated stomach versus a non-dilated stomach, which is not surprising really. So what we're saying is that if cats have got a stomach full of gas or other material, then they're more likely to have gas in the stomach and duodenum, which is kind of intuitive really. And also there's a difference between the amount of gas within the stomach and duodenum in cats that have homogeneous versus heterogeneous material within their stomach. So again, these cats that have material in the stomach, that they're more likely to have gas in the stomach and the duodenum, that's pretty intuitive. What are we taking away here? Well, so this result here, so cats that have GI disease are more likely to have gas within their stomach and duodenum when they're sedated versus non-sedated cats. Cats that have a dilated stomach are more likely to have gas in the stomach and duodenum than cats with a non-dilated stomach, and then cats with homogeneous and heterogeneous soft tissue material, they have differing amounts of gas within their stomach and their duodenum. So, in discussion, I think the thing for me to take away from this is that the vast majority of the cats, they didn't have any gas at all in their stomach or their duodenum. And so this technique, it's less relevant to cats than it is to dogs. So if 70% of cats, whether they're healthy, whether they're cats that present as being clinically ill for either GI disease or for non-GI disease, they're less likely than dogs to have gas in their stomach and their duodenum. And so the technique of doing a left lateral, a VD, and a right lateral is less likely to make a difference than it is in dogs, because there's less likely to be gas there to help highlight any sort of pathology, be it a foreign body within the pyloric outflow or the duodenum, relative to dogs. So this isn't a technique that is likely to be as useful in cats as it is in dogs, because cats just don't tend to have as much gas in their GI system relative to dogs. However, you are more likely to see gas in the stomach and the duodenum if you've got gastric dilation and you've got homogeneous gastric content in a cat. So there we go. In terms of the study itself, like I said, there's a few things that I would query. So the comparing the difference between the gastric dilation and the non-gastric dilation, that wasn't in the original names of objectives. The homogeneous versus the heterogeneous stomach contents, that wasn't in the original named objectives. I'm not really sure why they decided to do those statistical comparisons. I thought that the scoring system was a little bit elaborate and it was kind of unnecessary and sometimes quite confusing. So I'm not really sure we needed to go from 0 to 3. And these are categorical variables, and we're giving them sort of a continuous nomenclature. So it sort of suggests that a 3 is bigger than a 1, but it's not. It's just referring to gas in a different place. I thought that could be simplified, really. Maybe not necessarily to a binary yes-no system, but something that is easier to understand than the system that they had. And yeah, what I took away from it was that cats, unlike dogs, they don't tend to have much gas in their GI tract, whether they have GI disease or non-GI disease. So yeah, those are my thoughts on that paper. Does anybody have anything to add to this paper or any questions about it? If not, then we can move on to paper number 2, which is an ultrasound paper. So this paper, again, published last year in VRU. It's come from Ohio State, and sounds as if they also had some help from Iowa State University and the University of Florida. So this is an ultrasound paper, and it's looking at the ultrasound characteristics of feline urinary bladder transitional cell carcinoma relative to canine urinary bladder transitional cell carcinoma. So in the intro, they state that TCCs, they're rare in cats. I certainly haven't seen anywhere near the number of TCCs in cats relative to dogs. They tend to present initially with hematuria. Often they can be diagnosed with ultrasound, and the masses are often distant from the trigone, which is unlike canine transitional cell carcinomas, where the masses tend to be located at the trigone. So the aims and objectives for the study were to describe the ultrasound findings in 20 cases of feline urinary bladder TCC and compare those with the characteristics of 20 randomly selected canine transitional cell carcinomas. And they decided that they would be able to use the same criteria to evaluate feline TCCs as canine TCCs, but that a greater proportion of feline TCCs would be distant from the trigone, and not as many of them would extend into the urethra. So all those hypotheses are based on the existing literature and what's already out there about feline TCCs. So this was a multi-center retrospective descriptive case series. So essentially looking at the clinical records from 3 universities, so Ohio State, Iowa State, and Florida University, and looking at them from January the 1st, 2006 to July the 15th, 2018. And the search criteria that they used to try and identify suitable cases were the words transitional cell carcinoma, urinary bladder, and cat or feline. They recorded a whole bunch of information about each of these cases. So how they presented, how big they were, some of the blood test analyses as well, like hematocrit, how long the clinical signs had been going on for, how the TCC was diagnosed, and also the results of a complete urinary tract ultrasound. And when they were analyzing the ultrasonographic images, there again were a number of factors that they reviewed, and this is how they described them. So the masses were described as either broad-based or polypoid, single or multiple. In terms of their region, they described it as either dorsal or ventral or both, and the location within the bladder was described as either apical within the mid-body or at the trigone. They recorded whether or not they could see any color Doppler signal from these masses, and also the nature of the urine, so could they see echogenic urine or not. They looked at whether or not the masses were mineralized, and whether there was any ureteral or urethral involvement, and also whether or not the renal pelvises were enlarged, and they defined that as being greater than 2.6 millimeters, whether there was any evidence of any local lymphadenopathy, and finally any disruption of wall layering. We'll cover those. So for the comparable canine cases, this was something that was handed over to Ohio State only. They looked from 2006 to 2018. You needed to have a confirmed transitional cell carcinoma, be a dog, have had an abdominal ultrasound, and they identified 83 cases and then selected 20 of those cases randomly to match the number of feline cases that they had. So they had 20 cats and then 20 dogs, and that were matched. They are pretty comparable in terms of their ages and their sex. So the dogs obviously a little bit bigger than the cats. So the vast majority of the cats presented with hematuria, stranguria, and plaquuria, and that was also true for the dogs. So if we have a look at some of the results, what we can see is the results for the feline transition cell carcinomas at the top, and then the results for the canine transition cell carcinomas at the bottom. The feline transition cell carcinomas actually had a little more of a characteristic appearance than the canine, in that there was less variation. So the vast majority of the feline TCCs, they were broad-based, they were singular, they didn't extend into the urethra, they had a positive Doppler signal, there was anechoic urine, and there was disruption of the wall, pylectasia, and there was no evidence of lymphadenopathy. So the only feature really of these feline TCCs that was a little bit ambiguous was the mineralization. So about half of them looked mineralized, and about half of them didn't. But the rest had this pretty characteristic appearance. So broad-based, singular, with Doppler signal. Now the canine TCCs, again, similar, not quite as characteristic as the feline. So the canine TCCs also were broad-based and singular, the vast majority. For the urethral extension, more of the canine TCCs extended into the urethra versus the feline. So 35% had direct extension into the urethra, whereas for the feline, only one of them did. So canine TCCs more likely to extend into the urethra, and that was a significant difference. Only 50% had Doppler signal, whereas 66.7% of the feline TCCs had Doppler signal. Same as for the feline, could be mineralized, could not be mineralized, so about half and half. Just like the feline, all of them had disruption of wall layering, and the vast majority of them also had evidence of pylectasia and no evidence of a lymphadenopathy. So the main difference between the dogs and the cats here is that the canine transition cell carcinomas are much more likely to extend into the urethra versus the feline. If we look at where these TCCs were located, the majority of the canine TCCs were at the trigo. Well, not all of them. So you had 35% that were apical, even in dogs, but the majority of them were at the trigo. Whereas in cats, it's much more of a mixed bag. So about 35% were at the apex, 35% were the mid-body, 15% were at the trigones, so actually less likely to be trigonal than either mid-body or apical. And then a few cats had TCCs that were affecting multiple regions. So the main difference here is canine TCCs more likely to be at the trigo. They don't have to be, because they could be at the apex as well. Cats, they kind of could be anywhere, but they're more likely to be at the apex or the mid-body relative to the trigo. So the discussion, they summarize all of these key characteristics for feline TCCs. So they tend to be broad-based, singular. They don't tend to extend into the urethra in cats, whereas they do in dogs, have a positive color Doppler signal and disrupt the wall. And you might also see some anechoic urine and no evidence of pylectasia or lymphadenopathy. In terms of their location, Feline TCCs, much more likely to be mid-body or apical. Canine TCCs, much more likely to be trigonal. Okay, so for me, that was a really nice, simple, descriptive, retrospective study of canine versus feline TCCs. I thought it was really useful. Tells us exactly what to expect with a feline TCC versus a canine TCC using ultrasound. So yeah, does anybody have any comments or questions about the ultrasound paper? Everybody happy? Great. I thought that was a nice paper. So the last one, which is our CT paper, is inspired by a case that we saw recently at LVS. So a little French bulldog that had a splenic torsion. So this paper published this year, produced by Cambridge and VetCT. And this paper looks at the CT characteristics of primary splenic torsion in 8 dogs. So splenic torsion, pretty non-specific in terms of the way patients tend to present. So most commonly with abdominal discomfort or distension. It's not uncommon for a dog with a splenic torsion to have abdominal palpation and for the vet to be suspicious of abdominal mass. And then occasionally patients with a splenic torsion will present with acute GI signs. So using ultrasound is usually the way to diagnose these cases. And typically you'd expect to see a big spleen, so splenomegaly. The spleen would be in an abnormal location. So the head of the spleen normally would be on the left cranial abdomen, and it would be very dorsal, so it won't be in that position. It'll be somewhere else. And you'll often see some evidence of thrombosis, so echogenic material within the lumen of the splenic veins or arteries. Reduced blood flow is going to go together with the thrombosis. And in the literature, you have this starry sky pattern that's described as being pretty pathognomonic for splenic torsion. So the splenic parenchyma will be profoundly hypoechoic, and there will be numerous hyperechoic foci throughout the splenic parenchyma, giving it this starry sky pattern. So if you see that, then that, as I say, it's a pretty sure sign that the spleen has twisted and there's a splenic torsion. Other things you can see would be this hyperechoic triangle of fat around the splenic hilus, and also peritoneal effusion. So patients with splenic torsion not uncommonly will present with some abdominal fluid. Up to now, the sort of CT appearance of a splenic torsion, the sort of changes you'd expect to see would be a large spleen, which would be an abnormal location. The spleen wouldn't tend to enhance after giving contrast because of the torus vessels, and you might see a focal whirl sign as well. So in any number of diseases that result in torsion of an abdominal organ, so you can see a whirl sign. So you can see it in patients with colonic torsion or bladder torsion. So you see this hyper-attenuating wispy whirl of soft tissue around the structure that's twisted. So those are the sort of things we'd expect to see in patients presenting with suspected splenic torsion that are having a CT examination. So one of the things that I think would be interesting would be to just pull one of the references that's given in the introduction. So this is a paper that was published a few years ago now, so back in 2016 in JAVMA. And this is a paper that looks at primary splenic torsion in 102 cases. So I thought it would be useful just to have a look at the sort of ultrasonographic changes that De Groot reported in 102 cases of dogs with primary splenic torsion versus the 8 that we're going to look at in a little bit more detail using CT. So in these 102 dogs, the vast majority were big dogs, so German Shepherds being the most common, followed by Great Danes. So this is typically something that occurs in large breed dogs. More bulldogs than I may be expected to see, so 11% of them were bulldogs, and quite a lot of them were other pure breed. Unfortunately, they don't really explain exactly what other pure breeds are included in this 44.1%. But I think it's fair to say that typically this is a condition that we tend to see in large breed dogs. So of these dogs, 82 had abdominal ultrasound, and the vast majority of them had a big spleen. The vast majority had reduced splenic blood flow. Now, they don't use the term starry sky. They call it a hypoechoic splenic parenchyma. Now, it's not clear whether a hypoechoic splenic parenchyma is synonymous with starry sky, but not that many of them had that, so less than 50%, which I was surprised by. About half of them had peritoneal fluid, and the rest of the changes, so abnormal splenic position, hyperechoic mesentery, and splenic emphysema were much less common. So the thing for me that was most surprising was that I expected to see maybe 90% of these dogs having a starry sky pattern on the abdominal ultrasound, and that really wasn't the case, which I was quite surprised by. So up until recently, all of the dogs that I've seen with a splenic torsion and ultrasound have always had this starry sky pattern, but it turns out that they don't always have it. In fact, it can be, well, only about half of them have it, according to the results of that study from JAMA. So this study, they wanted to just simply describe the CT characteristics of primary canine splenic torsion. This is, again, a simple retrospective, multi-center descriptive case series. They used the VetCT database to come up with the cases. They looked at data from 2013 to 2018. In order to be included in the study, you had to have a diagnosis of splenic torsion, and that had to be confirmed surgically. And a whole bunch of stuff was recorded about all of these patients, including their age, their sex, their weight, their breed, how they presented, what was found on ultrasound, as well as cytology, the region of the patient that was studied using the CT, how long they were in the hospital, when the study was performed, and whether or not the diagnosis was made via surgery or post-mortem, and also if there was histopath available, what the histopath results were, and how long the patient suffered from this condition. So if splenic torsion wasn't confirmed, they're excluded, and if there was any other sort of concurrent abdominal pathology, they were excluded. On the CT, they looked at the size of the spleen, the position, whether it was lateralized, so shifted to the right or the left, its shape. They used this classic C-shape spleen to describe the shape of the spleen in these patients with splenic torsion. They also looked at the margination and described it as either normal, round, or irregular. For the splenic parenchyma, they defined it as either homogeneous, heterogeneous, or nodular, with some focal heterogeneity. And they looked at the attenuation pre and post contrast. They defined enhancement as greater than 10 Housefield units. So if the splenic parenchyma's attenuation was more than 10 in the post versus the pre, then that was considered as enhancement of the spleen. And they measured the attenuation using 3 defined regions of interest. They were 5 millimeters squared, and they positioned them on the head, the body, and the tail of the spleen. So their method for calculating attenuation was standardized. They also described whether or not there was any contrast filling of the intrasplenic vasculature. If they could see a whirl sign, then that was recorded as either yes or no. They looked at the attenuation of the center of the whirl, and also whether or not there was any evidence of any venous thrombosis, splenic venous thrombosis. They recorded whether there was any peritoneal effusion, and also looked at the size of the splenic lymph nodes and the position of the stomach. So in this paper, they only had the 8 dogs. The age of the dogs ranged from 3 to 16 years, with a mean of 7. The majority were male-neutered, although there were also 3 female-neutered and just one male entire. The breeds of these dogs, again, mostly big dogs. So Schnauzers, German Shepherds, there's a Bulldog in there, there's an Akita, a Golden Retriever, and a Swiss Mountain Dog, which is also a big dog, and then a crossbreed. And these patients were recruited from 5 different countries. So this is not something that's that common based on these results. So this is looking at the entire VetCT database over a number of years. And these cases were taken from 5 different countries. So this is not something that you see every day. So the majority of these dogs presented acutely. They were lethargic, they had a palpable abdominal mass, and had a peritoneal effusion that was detected. The majority of these dogs that had a peritoneal effusion had a hemoabdomen, which again was not something that I'd seen before our recent case, but 4 out of the 5 of these patients that had a peritoneal effusion had hemorrhagic effusion, and roughly half of them were anemic. So all of them had a big spleen, and all of them had a C-shaped spleen. The majority of them, so 6 out of the 8, didn't have any splenic enhancement. So the attenuation of the splenic parenchyma in the post-contrast was about the same, or certainly less than 10 Housefield units relative to the attenuation in the pre-contrast. The majority of them had a whorl sign, and of those that had a whorl, the majority of those patients also had a hyper-attenuating whorl. So the stalk of the whorl was very bright on the CT. And again, 6 of the 8 had peritoneal effusion, and they all had a normal stomach. So when the spleen moves around and it's a primary splenic torsion, it seems like the stomach doesn't tend to follow. So let's take a look at some of the images that are included in the manuscript. So we've got dorsal projections of this is the whorl sign. So we can see that we've got these streaky areas of hyperattenuation that are just swirling around a central hyper-attenuating focus. And we can see that in both A and C. And we've got B and D, which are both transverse images, which show the hyper-attenuating whorl in a transverse bisection. And then D, which is transverse, it's a little bit oblique. And these are pre-contrast as well, so you can see the difference between B and D. This is a post-contrast image. We can see the kidney is lit up with contrast, and in D, kidney, there's no contrast in that kidney. So this is a pre-contrast image, and still we've got this hyper-attenuating center of that whorl. So we've got the whorl, we've got the hyper-attenuating center of the whorl. I think this is a sort of typical example of the kind of C shape of the spleen. So that's how the spleen tends to look, like a big C. This one's a little bit lateralized. And then we've got, like I said, the hyper-attenuating center in that whorl. So of the 8, 7 of them had histopathological analysis, and none of them were neoplastic. So 5 of the 7 were congested, 4 were a bit necrotic, 2 were a little bit hemorrhagic, and then just the 1 of them had some evidence of some myelolipomas. So if we put a dog through the board, the CT scanner, and we suspect that it has a splenic torsion, what would we expect to see? Well, we would expect to see an enlarged spleen that has a homogeneous attenuation with a C shape that has smooth, round margins that doesn't enhance, with an associated whorl sign with a hyper-attenuating center of the whorl. We might also expect to see some abdominal fluid. In terms of, well, how many of the cases didn't really fit into that category, there were 2 out of the 8 that had some enhancements, and there was 1 out of the 8 that didn't have a whorl sign. So occasionally you could see some enhancement of the splenic parenchyma, but bear in mind that that's defined here as being greater than 10 Housefield units. And you don't necessarily have to see a whorl sign in order for it to be a splenic torsion. So I suppose if everything else fits and you have all of the other changes, but you can't see a whorl, that's not a reason not to send that dog to surgery. They also talk a little bit about what might be causing the hyperattenuation of the pedicle of that whorl, because it's kind of a curious finding. It's difficult to know exactly what's causing that. And they suggest that it could be some thrombosis in the vessels. So all of those vessels were all twisted around. So there's going to be negligible flow in those vessels, which is going to predispose them to thrombus formation. And if there are thrombi in those vessels, then they're likely to be more dense, which might result in those vessels appearing hyperattenuating. That's related to the density, like I said. So if those vessels are all squished up together and they're full of thrombi, they're going to be more dense and they're more likely to be hyperattenuating, which I think is a reasonable suggestion. So I thought this was, again, a really nice study. It's a simple study, just a retrospective descriptive study. It tells us what we need to know about what we'd expect to see if we put a dog through the CT that we suspect of having splanchnic torsion, or even a dog that goes to the CT that's not expected of having a splanchnic torsion, like the case that we saw recently. So yeah, does anybody have any questions or comments about paper number 3, which is our CT paper? In which case, that is all 3 papers for today. Thank you guys very much for joining me for the September edition of LVS Journal Club. This session, I believe, will be available online to review, should you choose to do so. So yeah, thank you all very much for joining me.
Thanks, Ian.
Okay.
Thanks, Ian.
Thank you.
Thanks.